Hi, my name is Dr. Dana Wasserman, and this is Tough Talk with Dr. Dana. Today's tough topic is dissociative identity disorder, which is surely a tough topic for many who have lived with it or who continue to live with it. But first, please read the disclaimer and listen carefully to these important words. I'm legally required to tell you that I'm not providing psychological services and that this isn't intended to treat, diagnose, or cure any psychological issues you may have. I will be sure to honor your questions so that if necessary, you will know better when to seek help. So today we are going to talk about dissociative identity disorder, or what used to be called multiple personality disorder. Dissociative identity disorder, or DID for short, is a mental illness that has as its roots some significant trauma during one's young developmental years, and that has as its consequence a kind of splitting of one's psyche, a dissociative process, if you will, that causes the formation of various identities, personalities, or alters to form as a defense against the terrible things that have happened. These alters or separate personalities can arise at any time, and they are understood to be out of that person's conscious control. This is fairly heady stuff, so let's unpack this mental illness carefully and with the utmost respect. Let's start with dissociation. Dissociation is a defense mechanism, a coping mechanism against something such as something terrifying in which one separates from him or herself and the traumatic experience. Let me explain further. Daydreaming is a good example of dissociation. Imagine you are in school in a really boring class. You rest your head on your hand, and next thing you know, you are ensconced in another world, oblivious to the lecture and the sounds of other students around you. Indeed, you may even forget where you are. Suddenly, a teacher roars your name, and you are thrust back into reality, even though it may take you a few minutes to fully readjust to the world in front of you. This should give you a taste of dissociation. Dissociation further involves a complete dissolution of awareness, memory, identity, and/or perception. These are mental processes that exist without us ever really truly being conscious of them. But once there's a disruption in one of the above stated processes, there can be an immediate interference in daily functioning that can sometimes be quite profound. With DID, these personality states or alters can be incredibly distinct as they may have their own names, age, race, body type, temperament, and self-image. Sometimes an alter, a separate personality, may not be human at all, but an animal. Let's talk about the symptoms of dissociative identity disorder. And this comes from the Diagnostics and Statistical Manual, number 5, the big book from which we clinicians diagnose. Number 1, disruption of identity that involves at least 2 or more distinct personality states. Culturally, this may be seen as an experience of, quote, possession. This disruption in identity involves a fractured sense of self and loss of a sense of agency, accompanied by shifts of affect, which is the range of mood, behavior, consciousness, memory, perception, cognition, and even sensory motor functioning. The above are either observed by others or reported by the person him or herself. Number 2, there are many gaps in the memory of everyday events, important personal information, and/or traumatic events that are significantly different than simple forgetfulness. So we're not just talking about leaving your car keys on the kitchen table. These are entire blocks of time, anywhere from days to weeks to months, in which there's absolutely no memory of what has transpired. These symptoms can cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. These symptoms are not part of a normal and accepted cultural or religious practice. So what they're saying here is this is not typical in any kind of cultural mandate or practice. This is something completely separate from that. And note, it says in children, these symptoms differ from imaginary playmates of fantasy play. So as children, it's very common to have an imaginary friend. I mean, we've seen that even through Sesame Street with Big Bird and Snuffleupagus way back in the late 60s and early 70s. But I date myself here. The fact is that having DID transcends far greater than just having an imaginary playmate in children. And these symptoms are not attributable to the physiological effects of a substance, such as, having a blackout from a long alcohol binge, or another medical condition, such as complex partial seizures. But it's important to note that these symptoms are only part of the clinical picture. Let's look at the complex causes. The primary cause of DID is typically severe, prolonged, and extensive trauma during early age periods of development. The usual types of trauma are physical, emotional, and/or sexual abuse. In addition, accidents, natural disasters, and war, or even an early loss of a parent or severe isolated illness, these are all traumas, could contribute to the development of DID. In fact, the development of DID is considered to result from a number of factors, and they are: number one, as I said before, recurrent episodes of severe childhood abuse. Number two, a lack of safe resources to buttress against overwhelming trauma. Number three, the ability to dissociate quickly. And number four, further development of the use of splitting as a survival skill. Splitting here is being referred to as, for example, that there is now another identity that can face the trauma while the primary identity is protected by the stronger identity. There are other characteristics of DID that are important to examine. Number one, difficulty remembering significant chunks of childhood, more than simple forgetting. There are years, in fact, of just simply forgetting that part of childhood. That's rather distinct. Number two, inexplicable events and being aware of them. For example, finding yourself somewhere and realizing you have no idea how you got there, or finding receipts to places you have been or bought something and have no recollection being there or buying things. Number three, these periods of memory loss are frequent and they happen repeatedly. Number four, then a sudden return of memories, almost like a flashback of traumatic events, that suddenly you have a memory of where you are or where you have been. There are feelings of what are called derealization and depersonalization. Derealization means feeling disconnected from one's environment and everything within it. Depersonalization, on the other hand, is feeling as though you are a detached observer from within oneself, almost like an out-of-body experience. There is also symptoms of harming yourself. There is noticeable changes in handwriting even. And lastly, fluctuating levels of functioning, from high functioning to essentially disabled. The rates of DID. DID is found in only 0.1% to 1% of the population, making this an extremely rare disorder. The symptoms can manifest at any age, and females are more likely to live with DID than males. It is noted that women are more likely to present with acute dissociative symptoms, whereas men are more likely to deny symptoms and trauma, and that they are more likely to manifest violent behavior. Comorbidity. I've talked about comorbidity in various episodes, and I'll just remind you, dear audience, again, that comorbidity is a co-diagnosis or a number of diagnoses applied at the same time. So for DID, there are a number of them. In fact, there are a number of other disorders that can be found with DID. Most develop post-traumatic stress disorder and other trauma and stressor-related disorders. Depressive disorders, personality disorders, especially avoidant and borderline personality disorders, somatic symptom disorder, which I spoke about in the last time I gave a talk, substance-related disorders, anxiety, panic attacks, and phobias, and these are related to flashbacks or reactions to certain triggers, eating disorders, sleep disruptions, severe headaches or pain elsewhere, and lastly, sexual dysfunction, including addiction and avoidance. So let's talk about intervention and treatment for dissociative identity disorder. It is ideal that the earlier the better for intervention of prolonged abuse and trauma in order to prevent the widespread psychic splitting that can lead to dissociative disorder, or more specifically, dissociative identity disorder. That said, if you have symptoms such as significant inexplicable loss of memory, a frequent sense of derealization and depersonalization as I described above, a significant change of behavior when under stress, it is important you seek out professional help, particularly if you have thoughts of self-harm, harming yourself, or having thoughts of ending your life. DID does not typically resolve on its own. It requires treatment that may last for years for the purpose of having one learn to integrate these disparate identities into a cohesive whole, a solid sense of self. However, relapses are typically unavoidable. Environmental stressors, substance abuse, and very strong emotions such as anger can lead to the reemergence of symptoms as mentioned above. There are, however, some recommended therapeutic modalities for DID. Number 1, psychotherapy. Individual long-term psychotherapy, we're talking from what I have read, anywhere from 5 to 7 years, is the most common form of treatment for DID. Therapy is also utilized for working through the trauma that may have served as a catalyst to the DID in the first place. Next is family therapy. This is recommended to help inform the family about DID and its causes. The family will need to understand the changes taking place as one ventures through the therapeutic process, as well as what to look out for when there is a relapse of symptoms. Number 3, group therapy. This may be helpful as people with DID can commiserate with one another and find a sense of solidarity. However, some might not do so well because of being perhaps privy to other people's identity shifts in real time. That might be triggering or perhaps too overwhelming. Regarding medication, there is no medication specific for DID, but medication may be used for the comorbid depressive and anxiety disorders as well as post-traumatic stress disorder. Something different I wanted to bring up here is dissociative identity disorder in the media. Because of the rather extraordinary nature of this mental illness, Hollywood had taken it upon itself to produce movies and television shows with DID as a central force. I wanted to point out 3 that are worth watching, not only because of the stellar acting and direction, but also because of the thoughtful ways in which DID is portrayed. Now, these are my opinions, and I'm sure some people may disagree, and perhaps vehemently. Number 1. This movie is called The Three Faces of Eve, starring actress Joanne Woodward. This 1957 movie was a hallmark in taking a more clinical look at mental illness, and specifically DID, then called multiple personality disorder. Beware though, it is very dated, very antiquated, especially its portrayals of men and women, and of course, therapists. But if you're interested in watching an early movie about DID, The Three Faces of Eve is excellent in that the acting and directing are first rate, and in fact it is based on a true story. Next is a mini-series called Sybil, and some of you may have heard of Sybil. This was a book written by Flora Rita Schreiber, I believe back in the early 70s, and was made as a mini-series in the mid-70s. It starred Sally Field as the young girl named Sybil, which was a pseudonym. And Dr. Webster was played by Joanne Woodward, who played the Woman with DID and the Three Faces of Eve. Sybil was a young woman at Columbia University, and she was an art student who sought out treatment. Her psychiatrist, Dr. Wilbur, discovers that Sybil has at least 12 separate personalities, and this too is a brilliant limited series. However, I warn you that there have been many questions of the veracity of the story that had come to light, and even I think a book or two had been written questioning the truthfulness of Sybil and her 12 personalities. So watch with caution. However, its portrayal is not exploitative, and I thought it is very thoughtfully rendered. And lastly, is the United States of Tara. I have a soft spot for this show. This was starring Toni Collette and John Corbett. This was a cable series starring Collette as a wife and mother who develops DID as a result of trauma from when she was a teenager in boarding school. And yes, we find out about the trauma near the end. It was sadly canceled after a few seasons because of low ratings, but it beautifully articulated her shifts into different identities when under daily stressors and the impact and toll her illness takes on the family. It is nothing less than stunning, and I cannot recommend it enough. So therein concludes my talk on dissociative identity disorder. So I'm going to see if comments work today, and let's see what we can do here. Technology is not really my forte, admittedly, but we're going to see what we can do here. Here we go. Hey, here we go. I have questions here. Fantastic. Okay, so I'll answer a couple of these. These look really good. You mentioned that DID used to be called multiple personality disorder. Multiple personality disorder. Is this still the case? Yes. People don't call it multiple personality disorder anymore. They call it dissociative identity disorder. And that's been, I think, maybe a couple of DSMs, a couple diagnostic and statistical manuals, because I think they wanted to focus more on not just the personality, but also the focus on the dissociative aspect, the fact that it's not just you're changing personalities, but also a major symptom is the memory loss and the blocks of memory loss that occur in conjunction with the shifting of personality states. How easy is it to diagnose DID? I would think it is extremely difficult to diagnose DID. Probably because if you think about it, if the person is having these lapses of memory, they probably don't understand what's happening in the first place. So you have to think, what brings a person into therapy? And I'm not sure that they would even recognize that these things would happen unless they started to have evidence that they actually had these lapses in memory, you know, like finding receipts and they don't remember buying something. Maybe they think there's something medically wrong with them, so they might go the medical doctor route, which is what I would think to be more typical, and have I would assume that it would be diagnosis perhaps at the hands of a psychiatrist, perhaps, rather than a psychologist or a therapist at first. See, in DID treatment, there are three stages of therapy safety. Safety and stabilization, integrating trauma memories, yes, and integration rehabilitation. Absolutely, that's correct. Can people live a normal life, have a steady jobs, and relationships must be difficult? Well, it's hard because I don't really know of many cases of this at all, except a few, and a few of them who have written about their experiences. But it is very difficult. I think the show United States of Tara really did a beautiful job of just showing how difficult it is to know who are you talking to this time and what to expect from this personality state versus that personality state. So I would think it is hard, but I think with appropriate therapy and support and integrating of identities and working through the trauma, I think it is absolutely possible. Let's see. Do other people forget traumatic experiences as a subconscious coping mechanism, for example, as a result of PTSD? I would think yes. I would think yes, as you know, that there would be a kind of uh, simple forgetting. Because remember, we would have, for some people who have a trauma, they might have flashbacks to a trauma that they don't remember. They know that something happened to them, but they can't quite remember. And they may get little fragments of snippets of memory that might suddenly come rushing back as a result of a trigger, or simply out of the blue at all. Let's take a look. I think we are actually good here. Let me see. Nope, I think we're good here. Wow, that was really fantastic. Those are excellent, excellent questions. Thank you very much for them. So thank you very much for listening to Tough Talk with Dr. Dana. I really appreciated these questions, and they were very, very stimulating. So I will see you next week. And until then, I wish you all the best. Bye-bye.